Hi guys, my name is Tiffany and welcome back to another video, and I have a special guest with me this week.
It's Herrick again.
This is Herrick, and watch our previous two other videos, which I think will be fun. But this one I thought would be even more fun because we're going to compare the differences between the NICU versus
Adult ICU.
'Cause anywhere with you feels right. Anywhere with you feels like Paris in the rain. Paris in the rain. When I'm with you, when I'm with you, Paris in the rain. Paris in the rain.
So you work in the cardiac ICU, and I thought it would be fun for us to compare kind of like our daily routine.
I see. Okay.
Right? Okay.
First
So
question.
first one is how often you do your assessments.
We do ours at least every 4 hours.
Okay.
But obviously we're assessing our patient almost every hour. So
Yeah, NICU is pretty much the same.
same thing.
I think it's more Q3 is our baseline because our babies eat every 3 hours. So we try to coordinate our care and do it every 3 hours with the feedings, but it really depends on the acuity of the patient. So the patient is more sicker, then we actually touch them less. So we'll do sometimes every 4 hours, especially if they're like NPO patients, like patients that don't eat, then we're like, we don't want to mess with them too often because it's going to agitate them. So we'll do a Q4. And if they're super micropreemies, then we do every 6. But it's kind of like you, where we'll still do it every hour because you got a patient that may need to be suctioned every hour. You have to check in your IVs, your lines every hour, make sure they're patent. So you're pretty much going like every hour, really. But they kind of give you a guideline. It's usually Q3 for us.
Okay.
And yours is Q4, right?
Q4 for the most part.
Okay. So tell me about like your acuity. Like what kind of patient assignments you get.
Okay, so let me see. We get patients that are septic. We get patients who have had stents placed or who have had a heart attack or post-cardiac arrest.
Okay.
People who just came from cath lab. So those are our typical patients.
Okay. And then your assignments are usually 2 to 1?
2 to 1,
1-to-1.
unless it's really high acuity, then we'll get a 1-to-1. And very rarely do we have a 2 to 1.
Okay. Ours is usually max we can get is 3. It's 3 to 1, or 2 to 1 or 1 to 1. 1 to 1 usually means they're super sick, but 2 to 1 is the most common. Like I think I would want to say 2 patients is the most we get most of the time, and the patients that our patient acuity or our patient assignments vary. Like it just really depends on the pairing, and what we determine by that is like what kind of oxygen support they're on, because usually if they're intubated we try to keep them 1-to-1, or if you're going to pair them then we put them with a more stable patient, because your intubated patient will probably keep you super busy, so then we try to give you a more stable one. We deal with a lot of micropreemies, and we do have a lot of chronic lung patients because they're micropreemies, so it just really depends how they do the pairing.
Same here. If it's like a fresh patient from cath lab, there's a lot more frequent assessments. For example, our pulses will be, we need to check them, I think it was the Q15. So, or like if you have, what's another patient? Patients that the drips, you have to titrate and their blood pressure can be very variable. So those require a lot of attention, so they'll pair that just 1-to-1.
Yep, we do the same. Or if we have super sick kids on a lot of drips like that, or we have to titrate often, then they try to keep it 1-to-1. So
Cool.
Okay, pretty similar. All right. Oxygen supports.
Oxygen support. So we have patients on ventilators and on high flow nasal cannulas and VDR4, because recently we've been doing that from COVID patients.
Oh, okay.
So that's as far as I know the extent that I've seen so far.
Would you say that mostly they're intubated?
Most of the time, yeah.
Like how many? Like 90% of your units usually?
It's hard to say because the last year hasn't been our typical patient population because of COVID.
Yeah. But let's say...
I'd say 75%. Usually when they're extubated, usually we're already thinking of transitioning them towards step-down unit. Yeah.
Okay. For us, oxygen support, so our lowest is like a low flow cannula, high flow cannula, then we go to bubble CPAP, we have CPAP, and then we have intubated patients on a ventilator. We do have oscillators and the VDR4s too.
That's like a lot.
Yeah, so we have like a wide range, and that's kind of the order, is that we would go like that. Let's see, common meds that you give.
Common meds? I think the most important ones are drips.
Yeah, so what are your common drips?
We have common sedation drips for patients on ventilators, so fentanyl and Versed is very common.
Okay, same with us.
And then, since I work in the cardiac unit, you really need to know your cardiotonic drugs, such as the ones that specifically act on the alpha-1 and beta-1 neurotransmitters. I think they're called? Yeah. So, like Levo, Vaso, Epi, Neo. Let's see, you need to know your, like, nitro, so calcium channel blockers. What else is very important? Amiodarone. Yeah. So those ones specifically, we get a lot, but for sure, yeah, sorry.
Okay. No, yeah, because you are cardiac ICU, so you definitely deal with a lot more cardiac drips for sure. Like NICU, the most common one is dopamine. Yeah. And then if you have a patient with like chronic blood pressure issues, then we'll give them something for that. But mostly when it comes to like the titrating blood pressure drips, then it would be dopamine. Other common meds we give, caffeine.
Oh, wow.
Which helps to stimulate breathing, which we give to our babies. We give our babies caffeine. And then every patient usually is on like a multivitamin and iron. We give a lot of diuretics on our unit too, so like Lasix, Diaril. Yeah, those are some of the most very common ones we give.
I see. You name it, like
these are like basic.
Ours can be, since I deal with adults.
Yeah.
We're dealing with adults with different comorbidities.
Right.
So, I don't want to target specific ones, but I don't think like, let me see.
I'm sure a common one you give too.
I know we give diuretics. Stool softeners. Oh yeah.
We give a lot of suppositories in the NICU.
But less than you'd imagine. Like usually they're not conscious, so usually they're sedated. But I'm not trying to think.
Any other, like, I'm sure you probably get patients with taking oral blood pressure meds too, right?
Yeah.
But since they are sedated, then they probably aren't taking it. You're all giving IVs.
Or we can put it through the G2. So, but I don't I mean, I'm like trying to think. With like cardiac patients, it's usually a mixture of like beta blockers, calcium channel blockers, or diuretics.
Yep.
So.
Yeah, very similar to ours, because we deal with a lot of patients with cardiac issues and chronic lung issues, so we do give a lot of diuretics for sure. So, let's see. Family members. So I feel like in NICU, because our babies don't speak, that we mostly deal with families. And I think, like, I don't know if you feel the same way being ICU, that a lot of times the families are a lot more tense and very anxious. I mean, this goes for all units, though. I'm not saying it's just ICU that families are like this, but I want to say that because they're in a critical state, do you feel the same, that the families tend to be a lot more, like, anxious?
So my experience is very little, just because since COVID happened, visitors haven't been allowed on our unit.
That's true.
And there's only a couple reasons why they would be welcome. One of them is if their family members on the verge of death.
Oh yeah, that's right.
So that's the sad part.
Yeah.
But the ICU, the patients are super sick, and a lot of times we have to prep the family member of what to expect.
Right.
The beeping, what machines that they might see, or tubes they might see. For example, almost all the sedated patients on ventilators have restraints on their arms. You know, family members don't expect their family member
see their family
to
member
be
like that,
restrained, but it's a safety measure,
right?
so the patient doesn't pull the intubate.
Don't pull their tube.
So that's the main thing, and the other thing is just kind of assurance, or like, since we have to do a lot of times, we have to update the patient through the phone. They just kind of want to know the basic status of their family member.
Right.
Yeah.
Okay. What about timeline? So in NICU, our patients can be there for a very long time, like months. Longest patient that we had was like over a year. Oh, wow. So that's usually how long our babies stay.
Typically, right now it's the COVID patients that are actually taking up the longest. They can go up to like 3 months even. But
say on
I feel
average,
like on average, maybe like a week or 2.
Oh, so it's very short. And then you try to transfer them to step down, right?
Oh yeah.
You try to get them out because you don't have a lot of bed space either, right?
No.
Because in my NICU at least, or the NICUs that I've worked in, our bed space is like 60 plus. So like
my unit, our patient load is 8. We just extended it because of COVID up to 12, and that's gonna permanently happen because we've just been getting so many patients lately. So it's just
so
different.
Yeah, so different because our babies stay for so long that we need more bed space. So yeah, going along with that, pros and cons about working in the ICU.
Pros and cons. Pros, the teamwork's amazing. We don't have any CNAs or lift teams, specifically at the ICU I work at. So your coworkers, your other nurses, your charge nurse is going to help you out. Doctors are relatively available. They're literally like a hallway across or right next to you. You have a little bit more respect with the doctors. They trust you. So I like that. And everything's much more responsive when you need something. When the patient's going, their blood pressure's tanking, you kind of have the meds readily available. And the critical thinking aspect is like a big thing that I really enjoy in the ICU. You kind of anticipate what's already happening.
Yes.
And lastly, I think the last thing is the organization of the unit. Everything's much more organized. And I think since it's more specialized, there's a lot less clutter and you can find things a lot easier.
Okay. So I feel like pretty much same with what you're saying too. Like the pros for NICU is definitely with the organization and like being able to critically think, being very involved with staff, and like at least in the NICU, like we have to speak on behalf of our patient. They can't tell us when we're in pain. I mean, your patients are intubated too, but like they really can't tell us anything. So we have to work as a team to figure it out together. But I would say some of the cons about working in NICU is that it is so specialized. I don't know if you feel that way about working in your ICU, but like we do get very limited with our diagnosis that we see, which may be I think it's a good thing because then I get very good at what I need to see and what I'm looking for. But for some people, I can see where the routine starts to get very similar and the diagnosis you see starts getting very similar. That people might want to branch out and try other things, but I don't know. I personally enjoy it, so I don't think of it as a con, but I can see for someone that might be.
Mine's a little different for adults. So at my hospital, the ICU is divided into 4. We have cardiac ICU, medical, surgical, and trauma. So in those specializations, I would say it's nice that I can focus on just the cardiac portion. And I wouldn't know exactly what to do with a trauma patient.
Oh, okay.
But at least I can translate what I know in med-surg, so I like that.
Yeah.
So I don't think that's a con for me, like the specialization. So
yeah, I don't know. I can't really think of cons.
Some cons for me personally, though, since I've worked there, is some of the nurses can be pretty nitty picky when they ask for a report.
Yeah.
They can kind of chew their young. I've seen that. Especially if, I don't know. I don't know, but I've just seen some nurses a little bit rougher with some of the new grads.
Okay. Because it is you need to learn quick, fast-paced environment that I can see how nurses that aren't picking up quick, they can get trailed behind, and there's an expectation, I feel,
definitely
in ICU that people have an expectation of like you need to learn quick. You do. And
at the end of the day, just keeping the patient safe is
right.
a priority.
Yeah.
So some of the nurses can kind of.
So I guess that is a con for both of us, where in ICU, NICU, and cardiac ICU, that fast-paced environment can be overwhelming for some people.
Yeah.
Yeah. So if you don't thrive in that, I mean, it takes time at least, is all I can say.
And the stress level is a little bit higher.
That's true.
Compared to, like, to me, when I go into med-surg, it's a breather for me. The type of stress, I was saying from the previous videos, if you haven't watched it yet, go ahead and watch it.
Look it above.
In med-surg, I'm prioritizing a patient who's really requesting for apple juice versus orange juice.
Like that.
Or a sandwich at like midnight.
It's like, really?
You know, versus a patient in ICU. I'm trying to get like...
keeping them alive. Like
their blood pressure.
Yeah, their blood pressure.
Or their heart rate's too high.
Yeah. So priority is a little bit different. Or like patient requests are a little bit different.
Oh yeah.
I think because you work in med-surg and ICU, that you kind of get a taste for both. And like I said in my previous videos too, that in NICU we have both. Like we have ICU, critical ICU moments, and we have stable. So I feel like, at least for me, I don't get burnt out because I have the balance.
Oh, good.
Yeah, where I can have critical, crazy, super busy, but I can also have stable feeder growers too. So I like that I can have both, because I could see how being in ICU only can be very overwhelming and you will get burnt out.
Yeah.
So it's nice to have a balance.
I agree.
For sure. So, all right. I hope you guys enjoyed this video, and I will see you guys in the next one.
All right. Bye guys.
'Cause